Alright guys, this is Dr. Moses, and we are going to briefly talk about psoriasis. So, psoriasis is thought to be an immune system problem that causes the skin cells to grow faster than usual. So, we don't know the true cause of this, but it's thought to be because an overactive immune system speeds up skin cell growth. So, a normal skin cell completely grows and falls off in a month. But with psoriasis, the skin cells do this every 3 to 4 days. But it's happening so fast that instead of shedding those skin cells and the skin sloughing off, it actually just starts to pile up on the surface of the skin and to create these plaques. So the cause isn't fully understood, but it is believed to be caused by genetics, the immune system, and the environment. What we do know is it is not contagious, and we do know that there are certain triggers for psoriasis. So those that are predisposed to psoriasis may be free of symptoms for years until the disease is triggered by some type of factor, such as infections. Strep throat or skin infections can be causes, weather, especially cold, dry conditions, injury to the skin, such as a cut or scrape, bug bite, severe sunburn could be causes. Smoking and exposure to secondhand smoke is thought to be an environmental trigger. Heavy alcohol consumption, certain medications like lithium, high blood pressure medications are thought to be a stressor or trigger, such as indomethacin, lithium, propranolol could be medications that we look at, and anti-malarial drugs are also thought to be tied to this as well. And then rapid withdrawal of oral or injected corticosteroids is also thought to be considered a trigger as well. So when we're trying to come up with a diagnosis, obviously, of psoriasis, one, we're obviously looking at the skin and looking at the physical symptoms, signs and symptoms, what the plaques look like. I've got a slide here in a second that goes over the different types of psoriasis. But we're really asking, is there a family history of this because there is such a strong genetic component to it? Have they had flares and precipitating factors? Do they know certain things that their body is really sensitive to that causes some of these flare-ups? And then also just asking, when was the onset? How long have they dealt with this? And what have they used as their treatment in the past to figure out how we need to go about treating maybe a flare-up? So, when we look at this, the common signs and symptoms include a patchy rash that varies widely in how it looks from person to person, ranging from spots like dandruff-like scaling to major eruptions all over the body. They can vary in color. They tend to be in shades of purple with gray scales, or brown, or black skin and pink, or red. So it depends on the skin color of the person that it's on will also impact the pigmentation of it. But they're thought to have these silver scales are very common on the individuals with white skin. Can have small scaling spots. This is more commonly seen with children. Dry, cracked skin that may bleed, itching, burning, or soreness. And they can have cyclic rashes that flare for a few weeks or months and then subside. So the different types of psoriasis. So we've got your most common, which is your plaque psoriasis. And these are these plaque raised patches with silvery white scales. There may be few or many, and they typically are seen on elbows, knees, lower back, and scalp. And they can be very itchy, painful, and can lead to bleeding. Gottate psoriasis primarily affects young adults and children, and it's usually triggered by bacterial infections such as strep throat, and it is seen more as a small dot-like lesion. Pustular psoriasis, which all those are little pockets of white blood cells, so it's rare, but they are clearly defined pus-filled blisters with reddened areas around it that are not infectious nor contagious and usually occur on the hands and feet. Inverse psoriasis, it mainly affects the skin folds of the groin, buttocks, and breast. It can be smooth, shiny patches of inflamed skin that worsen with friction and sweating. Nail psoriasis can affect fingernails and toenails, causing pitting, abnormal nail growth, and discoloration. And psoriatic nails can crumble or separate from the fingers and or toes. And then the last one here listed is your psoriatic arthritis. So this is a condition of it's a chronic autoimmune form of arthritis that is caused from this autoimmune psoriasis development and hyperproliferation of cells that can lead to joint changes similar to those seen in like rheumatoid arthritis. And so 1 in 3 who do suffer from psoriasis may actually then develop psoriatic arthritis as well. So what do we do for arthritis? What do we do for psoriasis? So treatment, whether topical or systemic, is something that we're going to choose based on severity, what type of comorbid conditions do they have going on, the efficacy of the treatment, their patient's response to treatments, and what they're wanting to get from their treatment. So we have to recognize the treatment's there to manage but does not cure psoriasis. So the first line that we see with psoriasis is our creams and our lotions or topical therapy. Your emollients and your corticosteroids are the most used topical agents. Your emollients are going to keep the skin soft while minimizing the itching and our pain. And then your corticosteroids, topical corticosteroids, provide anti-inflammatory actions to help with that area as well. There's also anthralin, which is similar to tar, and tar preparations, which are still used, just not as much as they used to be. But anthralin is similar to tar, can help relieve chronic psoriasis. It's a very stiff paste that they apply to lesions for short periods of time. So it's a very strong irritant and can cause chemical burns if it's left on too long or not washed off completely after treatment. So it is important that if they use this anthralin, that they make sure it doesn't come in contact with uninvolved skin. Tar preparations, like I said, so these suppress cell division and reduce inflammation. They were used historically as a primary treatment, but they're messy, they stain clothing, they smell bad, so a lot of people don't use them as much anymore, but you can still get these as like ointments, lotions, gels, shampoos, that kind of thing. And then we've got systemic therapy. So, we start typically with our creams and lotions, and then if we need to, we can go into systemic or oral medications, which are prescribed for patients with more than 5 to 10% of their body surface area affected by lesions. So things you can see would be like methotrexate, folic acid, and systemic retinoids can be used. Now, if they are using a retinoid, it is important to remember that this is a teratogenic substance. So if women are pregnant or hoping to become pregnant, they are not to take this medication. And if they are taking a retinoid, that they are using effective contraception to prevent pregnancy while on the medication. Your biologics, so there is a table in your book, 21.6, that breaks down the different biologic drugs. So there's like your tumor necrosis factor inhibitors, and there are like 3 different ones I think listed in your book over that. And then there's also your monoclonal antibodies. So just remember that biologic drugs are medications that come from living sources that target specific cells, proteins, and pathways in the body that are related to the immune system and inflammation. So you see like biologic drugs can be used like for cancer treatment, autoimmune, so pretty common in that aspect. So it's important that if they are taking a biologic drug, that they do not receive live vaccines when taking it, and to report any signs and symptoms of infection while taking the biologic therapy. Light therapy or phototherapy has been shown to be beneficial in controlling psoriatic lesions. There are specific offices that use UV therapy. There are specific ways like wands, masks, that kind of thing that you can purchase that can be used at home that provides certain settings for UV outputs. But it is Important to note that like tanning beds and sun lamps are not recommended since there's a high degree of variability in the UV output from those products, and they can increase the risk of skin cancer and further damage to tissue integrity. So again, going and laying in a tanning bed is not necessarily the recommended treatment. I know you see people do it, but if they're truly using light therapy for psoriasis, we should really stick to more controlled, where we know how much UV output is being given to that person to prevent skin cancer and further damage to the tissue. And I do want to just say another thing to keep in mind is some people, definitely might have some self-esteem issues when it comes to psoriasis, just because the lesions, depending on the severity, just can be stressful for people who are worried about their appearance. So just make sure that you allow them to express their feelings. There are support groups for people who have psoriasis, so just knowing what their options are, hearing them out, and being understanding with their emotional support as well.